Hey, everybody, this is Michael White from North Central Florida. I'm here to talk to you today about precipitous delivery in the emergency department. And I figured I'd start where everything seemed to start in 2020 with COVID. At the beginning of 2020, my four kids were in school, they were doing well, and then the disease hit and school closures followed by Zoom classes, and then the ultimate decision that we would homeschool. So quarantine started good. We were baking and hanging out as a family. And then, as you can see, once we hit around Christmas, it was a little bit of a different story as the year wore on. Actually, it's been a wonderful experience for my wife and I. She's a doc with me in the ER, and our job, our shift work allows us to be at home with the kids. And they've actually really done well with school, and each have said they don't want to go back to a formal school now that they've experienced homeschooling. So I bring that up because COVID also had a major impact on our emergency department. We saw deliveries from time to time in the emergency department, and all my docs are family practice working in the ER. I'm the only ABEM guy. And so deliveries weren't much of an issue because they were not that frequent, and we had plenty of support within our group to get them done. But our hospital did not have an OB program and had no intentions of an OB program because the competing hospital across town provided that care. So in 2014, I was traveling around fixing ERs, and we had our fourth baby, and my wife told me to find a job locally. So I started running a shop with about 70 visits a day, about 200-minute discharge length of stay, which is the orange line. And I made some changes. And as our discharge length of stay came down, our visits started going up. And right around 2018, we reached a steady state for visits, right around 125 visits a day. And our discharge length stay continued down as we refined the processes. And then COVID hit right around April. You can see a big drop in our volumes. And that was managed okay by our group. But unfortunately, the competing hospital across town ended up shuttering their doors because they didn't have enough volume, probably because we had pulled the volume from them before. And when they shuttered their doors, our volumes once again shot up. But more importantly, the 300 deliveries they performed per year suddenly started coming over our way. Not all of them, but a significant number. So my hospital made a decision that they were not going to develop an OB program. The precipitous delivery would be handled by the emergency department. And the hope would be we would transfer to the closest receiving facility, which is actually in Gainesville, approximately 45 minutes away. But the reality is when somebody comes in active labor, the large proportion of the time they're going to be delivered in the emergency department. So I was very fortunate as an ABEM guy, having seen numerous deliveries and performed numerous before this even happened. And I was surrounded by a bunch of FP folks who have practiced independently in the past and were excellent at deliveries as well. And my emergency suddenly became the no prenatal care precipitous delivery center of excellence in North Central Florida. So when a woman comes in labor, either by EMS or through the front door, there always seems to be a lot of screaming, either from the expectant mother or from a family member. It's usually along the baby's coming out. So the first step is to hope your partner takes the patient. If you're working with somebody, if not, then tag, you're it. So I grouped deliveries into a couple different groups. Normal, although I would argue there's no such thing as a normal delivery in the emergency department. A nuchal cord, shoulder dystocia, breech, prolapse cord, and then I hit a couple other topics just very briefly for postpartum care. So most of the time in the emergency department, it's a hurry up and wait when it comes to precipitous delivery. There are cases where the baby's coming out immediately, but most of the time, somebody's still in labor and the cervix is dilating. For a woman who's never had a baby, that can be up to 8 hours from start of labor to full cervical dilatation. And for a lady that's had multiple, it can be 5 hours. But the baby's coming out stage is what I'm talking about. And even then, there's often a delay. For somebody that hadn't had a baby, it's usually about 45 minutes on average. And folks that have had babies, you're talking 20 minutes. And then placental delivery is about 5 minutes after the baby comes out. When somebody comes in screaming that the baby's coming on out, It's a rapid fire HPI, past medical history and exam. You want to find out if they have any medical problems, if they're on any meds. Hate to say it, questions like, do you take methadone or Suboxone are questions that I need to ask. Do you have any allergies? How many babies are in there? What's the due date? Very often, folks don't even know the due date due to lack of prenatal care in the area. And then you want to look, feel, and measure and see what you got. And then, of course, prepare to catch. So the first thing is women have been having babies long before doctors were, medicine was even a profession. So first thing is to do no harm. A lot of things will just happen on their own and you're there to support and help. So there's some basics. You want to introduce yourself. It's a strange thing to have a baby in the emergency department. And the more you can explain to mom ahead of time, the better off she'll be. You want to get ready. You want to get towels. You want to get a timer. I'll talk more about the timer in just a minute. And you want to make sure you have the right gown. You don't want those plastic gowns that we use for COVID. They're not good for holding on to a slippery baby. And then with contractions, you want to have mom push about 4 times with each contraction, about 10 seconds per push. And the idea is flexing that uterine muscle. If you can have mom space those out at about 10 seconds, she'll be much more effective at pushing the baby down as opposed to trying to do one long push. So mom pitches and you catch. That's the basic thing. Head comes out first and then it'll angle down and the anterior shoulder will come out. Then the head will kind of angle up and the posterior shoulder will come out. You catch and make sure you don't fumble. That's basically the key. As soon as the baby comes out, skin to skin, you want to get the baby up to the mom. You can do delayed cord clamping and then everything's good. So the bottom line is you want to hope for the best because most of deliveries are uncomplicated. You're talking north of 90%. Of course, having said that, you want to hope for the best, but plan for the worst. Because if the baby's not out in 5 minutes, about 45% or so will end up dying. And there's obviously huge morbidity associated with this as well. So when you're delivering a baby, the thing to worry about is when the baby's head comes out. That's kind of a branch point that needs to be highly managed. And as in the movie Alien there with the image to the right, they should have worried a lot more when the alien came out of the belly. If they'd managed that better, things would have been different at the end of the movie. So let's talk about nuchal cords. They happen in about 1/3 of births, so they're not uncommon. And when they come out, they can be, when you feel them, they can be kind of frightening. You got to make a decision. There's either going to be a loose nuchal cord or a tight nuchal cord when they happen. A loose nuchal cord is not a big deal. You can slide that over the head or even over the shoulder. My favorite technique is sliding over the shoulder. The baby's shoulder is not very broad. It's easy to get it over the shoulder, and that creates you enough space to deliver the baby with the nuchal cord, so to speak, still intact. Then the question becomes what to do about the nuchal cord if it's a tight nuchal cord. Do you leave it alone? Do you cut it? So one of the, the classic statements is the nuchal cord can be tethering the baby up, and that's why the baby's not delivering. That just really doesn't hold much weight when you look at the length of the uterine cord. It's about 20 to 24 inches, so close to 2 feet. And if you take the uterus minus where the placenta sits, you're at about 6 inches. And then the neck circumference of a baby is about 2.5 inches. And then from the shoulder to the belly button's about 8 inches. So you're talking right there about 17 inches. You got another 3 to 7 inches to play with of the cord. So it's probably not tethering the baby up. So you still have a decision to make. Do you leave the cord in place if it's a tight nuchal cord, or do you clamp and cut? For me, I leave it in place. I'll deliver through the nuchal cord. And the reason being is my hope is that there's at least some trickle of blood flow still going through to the baby and that the baby's going to come down and be delivered out. And if I clamp and cut the cord, then the baby's got to breathe to get oxygen into the bloodstream. So it's a tough call, and I don't think there's a definitive answer. Most literature actually suggests to clamp and cut. And a lot of the OBs that I talked to said just leave it in place, deliver it as possible, and reduce the nuchal cord if you can. So let's move on to shoulder dystocia. Shoulder dystocia. Time is all we have until we don't. And that's a true statement. A lot of times you don't think about time until it's too late or it's gone. And when I was writing this, I started to think about the 5 minute statement, and made me think about Lori Morgan's song, where she's talking to her significant other as she gets ready to leave. And she said she got 5 minutes to figure it out. Come shoulder dystocia or other difficult deliveries, you got 5 minutes and you got to figure that out. So shoulder dystocia is a problem of a bone on bone obstruction. And it can be unilateral or bilateral. So it can be just against the pubic symphysis bone, or it can be the pubic symphysis bone and the sacrum, but pubic symphysis bone alone is much more common. So where does the shoulder get hung up on the bone? In the pelvic inlet. And you can see in the pelvic inlet, that's where the pubic symphysis is, and the most narrow area is the AP direction. The transverse is the widest. So as you can imagine, if you get hung up in the AP direction, you want to try to rotate to get into the transverse direction to get the baby on out. So dystocia, you need to think about it when the head pops out. Remember, the head out is when it's super high risk. When the head's out and then gets vacuumed back or sucked back against the perineum, or if it's a difficult delivery to get the head out, you should be thinking about shoulder dystocia. And the baby really pins up against the perineum. And when it kind of goes out with the push of the uterus and then back, it's called the turtle sign. So you want to recognize when this happens, and then you really want to restart your thought process, because this is going to be a difficult delivery, or has the potential to be a difficult delivery. So you want to call a code yellow. That's to alert everybody that you're having a difficult delivery, and likely you'll need resuscitation of the baby as well as the mother. You have the mom stop pushing and you start doing. And right there's a picture of the shoulder wedged in against the pubic symphysis bone. So your first steps are to try to move that pubic symphysis bone around the shoulder, or the shoulder around the pubic symphysis bone. And that's done with two techniques, and you can do them in combination. The first is called the McRoberts, which a lot of folks know about. And patient has two legs, you need two assistants. Each of them grabs the legs and they hyperflex at the hips. And you want to make sure they don't pry the legs open. If they pry the legs open, that actually narrows the canal. So they're going to flex at the hips, and then you can have somebody applying suprapubic pressure, and they want to push down and out. That's called the Rubin maneuver, Rubin 1 maneuver, and it's done a CPR-like fashion. And you're going to push down the suprapubic down towards the vagina, and you will do it in a rocking-like motion. And you can try to rotate that shoulder down and under, kind of shimmy the shoulder underneath the pubic symphysis bone or off to this transverse aspect so that it'll slide on out. And you do those two in conjunction and you'll be successful about 50% of the time. And remember, you got about 30 seconds to do these maneuvers. If this doesn't work, you need to go on to your next maneuvers. And that's where the timer comes in. That timer, somebody should be managing that timer, kind of like when they manage to tell you you need to give epinephrine during a cardiac arrest, and it's time for the next dose. So next step, if the McRoberts and Rubin 1 doesn't work, is you're going to move on to the entry maneuvers. They're called entry because you have to put your fingers inside the vagina to try to unwedge that baby's shoulder. And you may need to push the baby's head a little bit in to be able to get your fingers in, since it's going to be extremely tight spot. The entry maneuvers, this is top center is what you got. Babies in transverse direction and the shoulders impacted in on the pubic symphysis. And you traditionally, they recommend rotating the shoulder in the direction of the baby's nose. So from this top picture, you would go counterclockwise to move the baby and try to get the shoulder unwedged. However, that's just convention. You can go in either direction as long as you get the shoulder unwedged. But if you need to remember a little way of doing it, always goes towards the nose. The nose knows the way. So Rubin, beyond the Rubin 1, had a Rubin 2 maneuver, which involved getting the fingers inside and underneath the pelvic rim there, and rotating the baby's shoulder manually to unwedge it. And you can see a couple diagrams of this. And your hope is that as you unwedge, you're going to have a give and the baby will slide it on out. Again, remember, you don't want anybody applying pressure up above, since that'll put a wedge tighter between the shoulder and the pubic symphysis bone. Next is a combination of maneuvers, and this is trying to uncork the baby. And I always think of uncorking a bottle of wine, because you have a bottle of wine, you turn the wine bottle in one direction and the cork in the opposite. In a similar kind of way, you want to unscrew the baby from the birth canal. You're going to go the anterior shoulder in the same direction you just did towards the nose, and the posterior shoulder, you'll go in the opposite direction. And your hope is to move the baby in a transverse manner, and so that the baby can slide on out, since the diameter of the pelvic inlet is greater at that point. If that doesn't work, you go into the posterior shoulder, and this is pretty self-explanatory. You just go at the back portion, put your hand in there, and you're going to rotate the shoulder anteriorly and try to get that shoulder unwedged by using the posterior shoulder. So let's say that those entry maneuvers do not work. You're going to have to go in deeper. The next step is to go in, and you're going to try to flex the elbow and grasp the hand. You have to grasp that with your fingers. Again, it's going to be extremely tight, but you got to feel for the fingers, and you're going to bring the arm up over the flexed arm over the chest and slide out. That is the posterior shoulder that you're working on, the posterior arm down towards the sacrum. And you can pretty much expect to have a broken bone for the baby when this happens, most commonly the humerus. And that is just part of the difficulty of getting the baby out, because the canal is so narrow and tight at that point. Having said that, if you're able to get that arm out, it reduces the obstruction twice as much compared to the Mick Roberts maneuver. So let's say that you cannot get that posterior arm out. Your next step, and then remember, you're getting about 30 seconds for each one of these maneuvers, is to roll the mom on all four and hope the gravity is your friend. So she can either go in all fours, or she can go in a running position. And again, once you get her in that position, you're going to try to rotate the baby as you had done before. You can rotate the anterior shoulder, then you can try to corkscrew, and then the posterior shoulder. If that doesn't work, you can try to deliver the posterior arm. And again, make sure that somebody's monitoring that clock, doing about 30 seconds per maneuver. So in summary, you want to recognize it, have somebody start the timer. You're not going to be able to manage how long you're doing each maneuver as you're focused on that, and somebody needs to be reminding you to change. First step is the McRoberts maneuver and the rock with the Rubin 1 suprapubic in a CPR-like manner. And there is, you can place a little bit of traction on the baby, but I'd be very cautious about that. Next would be to switch to the rotatory maneuvers. So you position, let's go back to McRoberts, position 30 seconds, try to get the baby out for 30 seconds, that's a minute. Then you switch and you go to the 3 rotatory movements, and you can try each of those for 30 seconds. That's going to put you at 90 seconds or 2.5 minutes total. You can go next to trying to remove the posterior arm, and then you can roll over onto all four, and you can try to repeat those rotatory maneuvers and remove the posterior arm. So you want to do these step by step, one by one. If you're not able to get the baby out with the rotatory movements, then you're in a really bad spot. A lot of people will talk about breaking the clavicle. Breaking the clavicle is much easier said than done, because what you want to do is break the clavicle anteriorly against a pubic symphysis bone. You do not want to push down on the clavicle trying to break it, because if you do, you're going to puncture, you run the risk of puncturing into the lungs and or the underlying vasculature. And going anterior to posterior, pushing down, is very difficult because of the tissue underneath. So you really want to try to grasp your fingers underneath the clavicle and go anterior to break it, if you're going to do that. But again, that's extremely hard to do. So the last part is, I said earlier about fundal pressure, and any literature you read tells you never to do fundal pressure. But in reality, if you look at the uterus as a whole, the uterus is a large muscle, and when it squeezes, the largest portion of the muscle is at the top, and it squeezes from the top to the bottom. So like so many other things in medicine, never is ever, never forever. It seems like everything that we're told we can never do someday becomes something different. This opinion of never applying fundal pressure was created years ago, and it's become a convention. with the idea that you would increase the wedge. However, there's also the chance that if you do this with manipulation, you might be able to unwedge the baby and get them out, certainly much more with fundal pressure than with suprapubic pressure. So dystocia summary, the best option is to have a delivery suite there, which of course we don't have. However, dystocia happens about 3% of deliveries, and 95% resolve with 3 maneuvers within 4 minutes. You want to remember 30 seconds to get them into position, 30 seconds per maneuver. And you never want to twist, yank, jerk that baby, pull on that baby, pry mom's legs wide open. And I always think about this because as difficult as my job can be, it could be much worse trying to deliver a calf from an elephant. So next, what do you think when you see the butt come first? Well, I can tell you what I think is if I'm going to have a breech delivery, thank God it's the butt first. Seeing the butt first is best because the problem being is that the cervix dilates as the baby comes down through. And if the head comes first, it dilates the cervix completely. But if something else comes first, there can be variable dilatation of the cervix. And if the cervix does not dilate and the baby's torso comes first, the cervix can lasso the neck and become an anatomic noose around the baby's head. And that's not exactly something you can just pull the baby through. So breech delivery, there's 2 broad groups of breech delivery. There's butt first and not butt first. And the not butt first is the footling. The footling is about 10% of the time. The vast majority of breech are going to be frank breech with the hips flexed and the knees extended. So what you want to do in a breech delivery is keep your hands off. I know that seems kind of crazy, but mom pushes until the belly button's seen, and then you are there to support the baby. You never pull on these babies. And schematically, what you're going to do is you're going to assist, don't do. And as the baby comes out, you rotate in the direction of the nose. So that's consistent with what we talked about before. You deliver the anterior shoulder and the baby continues to roll until you deliver the posterior shoulder. And then you let the baby hang by the nape of the neck until delivery. And this is the hardest part because you instinctively would probably like to pull on the baby, but remember that cervix is tight and there can be incredible trauma to the baby as well as the mother by trying to pull the baby out. So let's say that you let the baby hang for a period of time and the baby's turning blue and you're concerned about the baby dying, strangulating, dying. So if this baby is still no go, what you can try is you can try to sandwich the baby. What you're going to do is you're going to slide fingers posteriorly and try to get them in the baby's mouth and maintain flexion of the head. And then with the posterior aspect, you can use your hands to grab onto the shoulders. Then you can have somebody push down with fundal pressure, suprapubic pressure, kind of one and the same, and hopefully you'll be able to unwedge the baby from the cervix. If that doesn't work, then you're up to extreme measures because there's not too much else you can do. And the only real option is to cut the cervix itself. And you would cut this at 10 o'clock and 4 o'clock or 10 o'clock and 20 after. And the idea being at 3 and 9 is where the arteries are. So you definitely want to avoid that. And you want to be very careful cutting anterior, directly anterior and posterior. Having said that, this is going to be extremely hard to do given that equipment isn't always available, nor adequate lighting. And a lot of this you would have to try to do almost sight unseen. So let's move on from that to prolapse cord. So prolapse cord, the cord is hanging out of the vagina or it has come down, descended down. And ironically, this can be a tremendous emergency. This is going to require C-section. However, a lot of women will have a prolapse cord and walk in to a birthing center with the cord hanging out. Just having the cord hanging out does not mean the baby will necessarily lose blood flow, but obviously it's of concern. So what you want to do is you want to be careful not to manipulate the cord. If you manipulate the cord, it can put it into arterial spasm, and then you will cut off blood flow to the baby. So your goal is to support and then hope and drive fast or faster as possible. And you want to try to put mom in a position where gravity is the friend, and hopefully having gravity pull down on the baby and pull the head away from the cervix will allow that cord to stay patent and continue to nourish the baby until they can get to C-section. But there's nothing that you're going to do in a remote location like mine to be able to deliver a baby in the emergency department through a prolapse cord. Okay, so just briefly, I'm going to talk about some postpartum now problems. There can be a lot of postpartum problems. But in my emergency department, we're going to take care of the life-threatening ones as we get them as quickly as possible to a birthing center for any further care. And the big one is postpartum hemorrhage. Somebody can bleed out in as little as 5 minutes if there's a significant active bleeding. And so that's definitely going to need to be managed. So what you want to do is you got to find the bleeder, and this is not going to be subtle little blood. This is going to be significant. First and foremost, just leave the placenta alone after delivery. I mean, cut the cord, clamp, and leave it alone. It should pass on its own in 5 minutes. Don't create a problem for yourself by trying to pull the placenta out. There's no rush to pull that placenta, have that placenta delivered. So if you got a bleeder, you want to look first for the source of the bleeding, and that may be in the genital tract trauma, such as lacerations of the cervix or the vagina itself. Especially these things tend to happen more commonly in complicated deliveries. You can have uterine inversion, which is not very subtle. You can have retained products, and that's going to take you looking, or take you actually feeling inside the uterus to find those. And then what's most common is uterine atony. So the uterus just doesn't squeeze down. And there's coagulopathy, but we're not fixing coagulopathy in our emergency department. So if there's inverted uterus, you're going to want to push it back in. It's not really subtle. You use your hand and you guide the uterus back in. And then you're going to want to have your hand in there and start doing some massage of the abdominal wall to try to get that uterus to firm back up. And you're going to want to start oxytocin. Oxytocin is a great squeezer and is something that you should start early when you're concerned about postpartum bleeding. And you can give IM oxytocin, or more frequently, what we'll do is we'll put it 40 units in a liter of saline, give TXA, get blood, and I would just say prophylactically get the blood there. If you get the bleeding stopped, great, you can return it. If not, then I would start giving blood. And then you want to get the patient to a surgeon if you're unable to get the bleeding stopped. The other part is you can try mechanical pressure, and there's two broad ways to do this. Number one is you can put your hand through the vagina onto the uterus itself and apply abdominal pressure. This can be one person or two person. I would suggest two person. And then the other option is you can do a contraption such as this. A lot of people talk about putting Foley catheters, but the volume of the balloon in the catheter is not sufficient to compress the uterus. So you can take a bag and put in some towels and include in there some IV connection. And what you can do is slide that inside the uterus and then go ahead and tie off the end and then kind of inflate the bag with some saline, and that will apply some pressure on the inside. A lot of people talk about doing packing, but please understand, to manually pack a uterus, you're talking about 12 plus yards of 4-inch gauze. It's a lot of gauze to put inside there. Can be done, but start with simple, get the oxytocin going, apply pressure, make sure you do a massage of the abdominal wall, because very often that'll stimulate the uterus to contract down, and then you won't have to go to these extreme measures. So the last thing to talk about is hypoxia and the newborn. I've seen a lot of folks, when they deliver a newborn and the baby's blue, they get very upset. And very often they blame this on meconium. So this baby's debating if they should poop before delivery or after, or better yet, during delivery. All of those are obviously options. But when a baby comes out, I just want you to know it's okay to be blue. I'm not going to go into huge detail, but you want to get a right-sided pulse ox, which is preductal, and 60% pulse ox at 60 seconds is okay. Don't run for the oxygen. Oxygen's been shown to harm these children. And at 10 minutes, it should be greater than 85%. But even before then, it can run a little bit low. If you feel that the baby's not breathing well, you can bag the baby with room air. That's perfectly fine. But don't just jump to administering oxygen, since that can cause problems to the baby. So remember, it's okay to be blue at birth. So thank you very much. This is one of the many springs around where we live. It's a beautiful part of the state. I encourage everybody to come visit. It's much more laid back than South Florida, and I think you'll enjoy the weather. So signing off from sunny Lake City, Florida. Thank you so much. Bye.